Hey, what's up, everybody? My name is Dr. Ryan Smith. I am a faculty on the Fitness Athlete Division of Institute of Clinical Excellence. I teach the Foundationals course online with Mitch, as well as the live course for the Fitness Athlete with Mitch. And we also have our advanced course with Zach and Mitch. So I'm also COO of Recharge over here in Maryland, Ellicott City area. We're smack dab between Baltimore and DC. And I coach CrossFit classes there. I see patients there. Pretty much do all that jazz as well. So without further ado, we're going to dive into the topic today, and we're talking about the shift, but in terms of movement and loading. So let's start off with the concept of a lateral shift, which I think a lot of people are very familiar with and is very McKenzie-esque in an approach. But if someone comes in with back pain or hip pain, and you look at their overall posture and just a standard posture, and you see potentially a shift of their lumbar spine to the left or right, typically we see that as a lateral shift, and that usually takes priority in what you're going to treat first before anything else. In the McKenzie approach, we treat the lateral shift before we would go then treat repeated flexion or extension, because we know the lateral shift is going to change how that flexion and extension works. Makes a lot of sense, and the lateral shift with both a manual technique or with a person who's taught themselves the technique is something that's really beneficial and can help a lot of people, and is a really good place to start. I want to take that same mindset of how we view that for lumbar spine and low back pain and apply it to movement as well. So I'll have lots of individuals who come in with ankle, hip, back pain, etc., and we can often see that unilateral shift in that lumbar spine. Now, when it comes to their functional movement, watching them squat, deadlift, etc., if that lateral shift is still there, that's going to place a different load on one side of the body versus the other. And we have to understand this, because what we're trying to do now is when we're trying to help these fitness athletes get back into activity, help people get back to moving, if they're going to have an influence or their body has a strategy to move and load one way much more than the other, well, that's going to say, okay, if I give this person 20 squats, they aren't really doing 20 squats. They're doing 20 right-sided squats or 20 left-sided squats, or the load will always be shifted one way or the other. So that could be simply from a lateral shift. It could also be maybe the person's shifting one way or the other because their body's strategy is always to go to their strong side. Maybe they're shifting one way or the other because they have a joint that happens to be a little stiff or painful, so there's an increase of sensitivity there, and the body's trying to move one way or the other. Now, this can be very, very subtle to very, very extreme in what you visually see. But one way or the other, you have to be able to tease this out relatively quickly when you're trying to prescribe exercise and load people efficiently and effectively, right? From the extreme end, you usually see a squat with a quick shift in the bottom of the squat into the left or right hip, or you see a shift coming out of it, right? One usually dictates either strength or pain or sensitivity to the other, and the goal here is to try to make that more symmetrical. Now, I say that with an asterisk because, understandably so, not everybody is symmetrical, and symmetry is not necessary. But if you ask that person, where do you feel that? How do you feel? And you combine that with what you're seeing, generally they'll feel something, particularly one side versus the other. And man, if you can get them to feel slightly differently going up and down through that movement, not only are you changing the perception of the input and how the movement's being done over and over again, but they're also like, wow, I have some sort of control over how I feel based on how I move. So that's what you need to start looking for within those realms. Now, how do we go about doing this and loading this effectively? Well, there's some simple ways, right? If we're looking at overhead movements, we often need to look at the neck in terms of, are they loading appropriately, right? The spine is usually where we always start if we're trying to figure out, is there going to be a shift in loading one way or the other, right? Yeah, Brittany, absolutely. Build the bike from the get-go. If you can change the way somebody feels based on how they move, you're going to get buy-in. You got to build that bike repeatedly. It's an ICE concept that is through and through. So if we're in the upper extremity and we see them extend and tend to go back to one side or the other, right? We generally know that if they're trying to extend that cervical spine and they're shifting to the left, they don't want to load that right side of their spine, right? They don't want to close down those joints because closing them down is technically loading those joints. I'll usually use the example for patients of saying, hey, you know when you extend your elbow and you kind of feel that like end range, that bony block, and it actually feels good to, after a long period of time to stretch it out and get to the end there. That's the same way in kind of your spine in certain ways. So imagine if your neck is always going one way, the body eventually is going to want to crave to close down that joint the other way, just like it wants to extend its elbow if it was stuck here in a long period of time. If that elbow is stuck in a bicep curl for long periods of time, you can imagine eventually the body's not going to feel that great. The same thing applies for the neck, right? So that's usually the analogy I'll give to them because that makes sense. One, because they know and they get what this feels like. They're like, okay, when I close down my elbow, when I extend it, it feels like I'm at the end range of something. So I need to try to do that with the spine when I'm trying to load. So you look at that. You do all your other techniques to then get that loaded, right? ISTM, manual therapy, manipulation, whatever you want. A to B, I could care less, right? Eventually, they need to be able to move with loaded symmetry in that. So that can start with chin tucks, overpressure, and get them to do that, whatever happens to be. But what we're looking at for a movement then is what they look like overhead with this. Right? If they look then fairly symmetrical and you don't see a shift of the neck one way or the other, you can assume that both shoulders are moving and taking on the load effectively and mostly symmetrically for that. So that's kind of what we're looking through. The thing that complicates this a little bit is if you add in a bilateral lift to these individuals, especially overhead. So if I take somebody with a barbell and they're here overhead, anytime you have a bilateral lift and there's potential asymmetry because there's sensitivity or pain or just a strength or strategy to one side of the body or the other, generally they'll try to prioritize that barbell overhead to balance, and that shift is going to come somewhere else throughout the body. Now that could be through the cervical spine, it could be through rib rotation, it could be through thoracic spine, etc. But it's very sneaky and very subtle. And this is why this concept of whenever we're doing bilateral lifts, it's probably important to start using a lot of unilateral lifts for these individuals, especially overhead, because the body will always prioritize the balance and the safety of itself and the strategy here of holding something, whether it's a press or a clean or whatever it happens to be, and doesn't care about what happens down the chain. That distal strength and distal safety will always take precedent over whatever the heck's happening proximally, right? So we need to be able to see that. And that's why when we're going overhead with athletes, often a change to unilateral lifts while still being able to load them, like a landmine press, like a bottoms-up kettlebell press, can be so beneficial because you can keep loading them, keep getting those adaptations you want without having the body trying to recreate itself in a bilateral fashion. So that's the upper body in a nutshell for what we're looking at for there. Right? Look at the cervical spine and make sure that just the general sensitivity, strategy, or load is going somewhat symmetrical and try to correct that, but also ask that person how they feel when doing so, and they'll be able to hopefully get a different type of feel when they're going overhead. Watch their movements overhead, both unilaterally and bilaterally, to make sure that we're seeing this somewhat symmetrical load and also a feeling of symmetrical load, and that they're not like, my right shoulder just feels gunky every time I do this versus that. What can you do to help that person? Use your skills A to B to then get them loaded from steps B to C. So that's the upper body for that. For the lower body, it so much takes into the lumbar spine and the hip, right? And this is where we get into that McKenzie unilateral shift type loading, and oftentimes can be super beneficial along those lines. I would say lots of individuals who come in with ankle, knee, hip pain of some sort usually will tend to have some sort of shift, especially in a squat or a deadlift, one way or the other. Now, if you're like, okay, we help them with their pain, but that strategy of that body is still to shift away from pain or sensitivity or to the strength side, then a bilateral lift that you're giving them for rehabilitation and loading isn't doing what you think it's doing. And that's where we need to kind of keep funneling that into our head as we go through. So that's what we're shooting for when we're looking for that. So lumbar spine can apply. Unilateral shift, manual therapy correction if you can. Have them do one I love with the forearm on the side and kind of push that hip to the wall is another great one. But also if the hip just feels gunky, if the knee feels tight or tense, whatever that hip feeling is, use your treatment methods A to B to be able to help that, right? Oftentimes I'll see people have this massive amount of tension in the front of their knee or in their quad, and they'll try to shift over when they squat. A simple femoral nerve floss or anterior nerve floss like that can often alleviate that tension and make the squat look smoother. Not only look smoother, but the patient will be like, oh, I feel better within that motion. Then we can put load on top of that and move through. Then we can do that, etc. So that's a really good way to look at it. Same way with ankle mobility in terms of the squat, right? If someone has a previous history of injury and they haven't really achieved that dorsiflexion, if they're trying to do a full depth squat and they can't get that right ankle in that position and that knee to come forward, well, there's going to be some sort of torque or shift when they do so. That's going to change the load that you're putting on that person and predispose it one way or the other, or have some sort of shift that's going to put the load somewhere where you aren't intending it to. So that's kind of what we're looking at in terms of that, all the way up and down the chain for how the load is. So we kind of briefly went through the upper body and the lower body for this and kind of how you look. It all starts with the spine. It all starts with watching them move. It all starts with you asking them where do they feel that. If you get those three things down, you're going to be much better at dosing and prescribing your loaded exercise to that individual in front of you, and you'll probably have to do less reps, honestly, because then you can load them up more, and it can feel relatively good and different to them, and they'll be able to get through there to heavy, slow resistance exercise. That's what we're looking for. Now, when talking to patients, I usually categorize these exercises I give them in two ways. Number one being, if we're doing any sort of movement to work on sensitivity or trying to get that shift correction, if we'll call it that, I always call those, this is a sensitivity movement, right? This is movement to try to get your body to organize the way it feels a little bit better, so that way you can feel it this way, all right? I'll often take a video or photo of them of when they're moving versus when, and then after they do the treatment, they'll be like, oh, okay, I feel that, and I'm seeing it. There's some this buy-in of this kind of symmetry that we're trying to look for, and overall just how it feels. So those are like the sensitivity exercises I give them, whether that's nerve flossing, whether that's repeated lateral flexion, extension, flexion, what have you, anything of those are sensitivity. I make a clear distinction that those movements are not to build strength, but to help the body develop a new strategy and a new normal to go in a movement from there. Then I say, okay, now here's your strength exercise. This is how we're going to build you to be robust and resilient. This is your squats, your deadlifts, your whatever movement insert there. Those are my first go-tos, so that's where it is. So if you can get them to feel better and less sensitive, less painful, etc., whatever, those are different types of movements than the actual strength movements. I think that gets lost in some of the traditional physical therapy practices, is that they'll have a list of exercises that would be, whatever on the table, and they think we're building strength that way. I'm like, no, those are good exercises, but that's an awareness or perhaps a sensitivity exercise that isn't going to build your strength long term, and we need to focus on that, right? Unless they're doing thousands and thousands of repetitions a day of those exercises, that's not going to be what we're looking at. So the caveat with that is gait analysis for this, right? If someone comes into you with pain, etc., and you watch their gait, you have to understand people are taking thousands of steps a day. That's consistently low load, high volume over time. And that needs to be an important factor of, okay, if I can get this person to do some of these exercises that help with sensitivity, that improve their gait, man, we're going to maintain that loading that we want consistently. I love to see this post-op with individuals, or also anybody who comes back from an ankle sprain or any sort of movement that kind of tweaks one side versus the other. So those are important things to look at in terms of low load, high volume, such as gait. So to summarize, we're always prioritizing the spine, right? We're always looking at movement to see what do we see in terms of a shift one way or the other, or compensation in any way. That can be going towards the strength or the stronger side as a strategy. It can be going away from the painful or sensitive side as a strategy, right? And then from there, using all the tools in your toolbox to help get that person feel better based on what they say. Hey, Ryan, my left side feels gunkier than my right. Now after we did that, it feels a little more open, and I feel like it's pretty close side to side. Perfect. Now let's load you up. So spine, movement, how do they feel? Load them. In that order, you'll be really well off using all the tools in your toolbox. So I'm just about out of time, but I hope that the shift here gives you a better idea of, I'm trying to get into this idea and this paradigm. I'm going to start loading people with exercise and really build strength, really start to build these people up. But when I give them it's just not turning out the way I thought. Well, maybe it's because the way they're loading is predisposing one type of pattern, strategy, or side versus the other. And these are some great ways to start looking at, okay, how do I get more exact on my dosing prescription and the quality of the movement in front of me? So a quick few announcements of what we got going. Mitch and I are headed to New York City this weekend to teach our live fitness athlete course, and we're so jacked for that. I've never been in New York, period, or New York City. So I'm excited to go for that. Jessica this weekend's in Peachtree City, Georgia, for cervical spine management. Justin this weekend is in Minneapolis for total spine thrust manipulation. So if you're following any of the ICE social media accounts, we are going to be very active this weekend. Next weekend, we have Eric Chaconis in Sioux City, Iowa for extremity syndrome management, which is going to be a sweet course. May 19th and 20th, so getting into next month. Jessica's with C-Spine Management again at Winston-Salem State University, down there with Allie Hartman and all those yahoos. Jason, London's going to be in Blacksburg, Virginia for Rehab of the Injured Runner, which is a kick-ass course. Like, if you're in that Virginia area, go ahead and check that out. And then this weekend, Mitch and I are also starting our online fitness athlete essentials course, and I know our advanced concepts course is coming up here relatively soon. Those things have been filling up really quickly, and we've really enjoyed the progress and the work people have been putting into those. So hope you guys have a great rest of the weekend. Look forward to all the ICE social media posts here, and have a great one. Thanks.